All right. So shall we get going?
Yes, yeah,
All
please
right.
do.
I'm talking with Scott Kilpatrick. So Scott Kilpatrick is a surgical pathologist, a very senior surgical pathologist at the Cleveland Clinic Hospital. If I get anything
Sure.
wrong, Scott, let me
No,
know.
you're right. No,
And
absolutely.
he's been around forever at the Cleveland Clinic, as far
Seems
as I
like
know.
it, right?
Scott, you want to tell us a little bit about your background? And I'm always curious to know what led you to bone and soft tissue pathology.
Yeah, it's a really, yeah, and I can tell you exactly what led to that. Um, what I always wanted to do academics for the most part, early in my career. When I was interviewing to go into residency at the time, there was this push, especially along the Northeast, for residency programs to separate out anatomic and clinical pathology, right? Completely. So I had a lot of, debates, spirited debates, so forth, because I had a very good advisor, a director of anatomic pathology, a guy named Dr. Rao at the Medical College of Georgia, who kept saying to me, Scott, you don't know what the future holds, get both AP and CP. So I went that way, even knowing I wanted to, do an academic background. I'm very glad I did. So I've got boarded in both AP and CP, and I've had opportunities in my career to use it. Well, that led me, and also the other thing he told me, which turned out to be really good advice, was find a place you can get a good general residency training and then do a really supercharged fellowship. I'm glad I did that. My personal opinion was Mayo Clinic was a fantastic place to do a fellowship, and I may get chastised for this, but I would not have wanted to do a residency there, right? It's so big and all encompassing, but for fellowships, surgical pathology fellowships are all about volume. Right? The more volume you see, the more comfortable you are, particularly for rare entities. So I'm giving you kind of a lot of background leading up to where I was. So that led me to Wake Forest University. And while I was at Wake Forest was had just really started an orthopedic oncologic program. They had hired an orthopedic surgeon named Dr. Bill Ward, who has just recently retired, I found out. And, I wasn't sure what so special. I like pathology in general. I liked all aspects of pathology. But he was talking to me one time in the frozen section lab about orthopedics and orthopedic, surgery and this kind of stuff, and said, yeah, we need a pathologist here that has that kind of training. So I started thinking about it. Well, of course, I actually thought about, I love sports growing up. So one of the things I thought about at one point in my life was orthopedic surgery as a career. So that's what sort of really started it. Fortunately, the faculty at Wake Forest kind of rallied behind me, knowing I'd be coming back, from a fellowship. And that also sealed my fellowship training towards bone and soft tissue. And I kind of decided, I want to train with Dr. Uni. I really want to go to Mayo Clinic and train, which I'm forever grateful that I did. Just an unbelievably good pathologist. I learned an incredible amount from that man. So, that's how it started. It really started with a conversation with an orthopedic surgeon, being at a general residency place that needed that expertise. And that's what led to me down the road I am today.
So the reason, of course, we're here and talking to Scott because of this fantastic review in the Journal of Clinical Pathology with
Thank
John
you very
Reed.
much.
And
Thank you for the invitation.
And it's an awesome review. And so we're going to talk a little bit about non-neoplastic orthopedic pathology. And I think this is something that everyone sees, whether you're in the community. Well, it's definitely out in the community.
Yeah.
And most of it is classified as junk. A lot of us look at it as junk, but it can be quite troublesome. In fact,
exactly.
I think, even hips and knees can be pretty troublesome, right?
Yep.
I don't know how you sign these out, but
yeah.
I'm used to the Andrew Rosenberg approach. We divide the hips and knees, the degenerative joint diseases, into mild osteoarthritis, and then we call it severe if there's eburnation and subchondral sclerosis. Do you really think it's worth submitting sections from these specimens?
It's interesting. So I'll be talking about this at the International Skeletal Society, specifically about avascular necrosis. So I think that if we start at like the 10,000 foot level, which is usually where I start when I'm explaining this, one of the questions we have to ask is basically, are clinicians right most of the time, neoplastic or non-neoplastic? And the answer, of course, is yes. One of the arguments has always been against arthroplasty, at least in the last 20 years, has been related to the fact, well, it didn't change the surgery, but most of the time the surgery, when our oncologic surgeons do a hemipelvectomy, my confirmation of chondrosarcoma doesn't change their need to have done that surgery. You could argue why okay, I'm looking at it for margins or what.
Yeah.
I kind of get that. But in reality, most of the time what the clinicians think, if they think it's an osteosarcoma, it is an osteosarcoma, right? I am confirming it, and there's good reasons to actually do that. So I think if we're looking for pathology to change what happened to that patient initially or change the need to have that surgery, then we're not going to see the benefit of pathology. The flip side of that, though, is I think if we're looking at it as, providing a complete diagnosis, a quality assurance type measure, and possibly changing what happens to the patient after that surgery, I think that is a more relevant sort of discussion to have. So I try to start people out with thinking that, most of pathology, we're not changing the original surgery, whether we're talking about an arthroplasty specimen or hemipelvectomy. Most of the time, we're confirming a diagnosis that was already understood, but we are changing sometimes what happens to that patient afterwards. And we're providing a diagnosis, and we've all seen diagnoses that were incorrect on both neoplastic and non-neoplastic resection specimens. So I think there's another need too, and I'm going to dive a little bit more into this too, Vikram, when we talk about like degenerative joint disease. But the other need, I had an interesting discussion a while back with Tom Bauer when he was chair at the Hospital for Special Surgery, and it was about the other mission that academic centers have. And that is to promote research and to ensure that research is accurate. One of the concerns I've had, and I've expressed this with orthopedic surgeons after we published our series on avascular necrosis, was that I had seen a trend in their literature that was suggesting that, so in the old days, let me back up. In the old days, I'm just talking about 10, 20 years ago, the thought was that arthroplasty failure was more likely to occur in patients who had had the arthroplasty to begin with due to AVN than DJD. There had been a trend where surgeons were now saying, we're not seeing that difference anymore. And I couldn't help but wonder, well, is it because your diagnoses are no longer that accurate? In other words, you have AVN cases mixed with DJD and DJD case mixed with AVN. Is your data really accurate? And I think that's one of the roles that pathology provides. So we have another mission, to that. And then I think a third important point is what I believe major centers should do and what maybe minor hospitals should do may not be the same thing.
That's interesting.
This is another thing I've wrestled on. I mean, it may not be, depending upon, not to sound ivory tower, because I'm not trying to sound that way at all, but depending upon the expertise of the pathologist involved in a small community hospital, it may not make sense for them to examine all the specimens we examine, right? They may not be providing benefit for that surgeon. If they're not reliably able to separate AVN from DJD, or on those rare cases, subchondral insufficiency fracture, or, recognize it all, which we've seen happen before, I'm not sure it makes financial, sense or in the best interest of patient care. In regard to degenerative joint disease, I like it. Well, so specifically focusing on that, I like what Michael Klein said when he and DiCarlo did this huge study with, over 10,000 joint resections, and then had a nice article in CAP Today. He made the point that degenerative joint disease is the most common reason, of course, for arthroplasty to occur, but it's also the most commonly overdiagnosed condition clinically, right? And so if that's the case, then, and it's being overdiagnosed, is it being overdiagnosed, and conditions missed that have patient repercussions? And I think the answer to that is yes.
The gross does not match the microscopic image, but I did want to give you a sense of what avascular necrosis looks like. The gross does not match the microscopic. This is a very typical low power appearance of avascular necrosis. You'll see three layers essentially. The first layer is the intact articular cartilage that is alive. Right under that, the bone, the subchondral bone, is dead. And the third layer, a distance away, is the interface, intact articular cartilage, a dead subchondral bone. I can promise you that all of the osteocyte nuclei have dropped out. The marrow is dead as well and is often filled with its eosinophilic, intact articular cartilage, a dead section from the surface to the base of that wedge-shaped lesion. This is the interface between the living and the dead. And this is that interface. You can see fibrocartilage-like material here. Notice this is all living. Anything above this was all dead. And here's the reactive bone at the interface. And you'll see that this bone beneath the interface is living, is much younger, and it's a woman. But again, notice very similar features. Those three layers, the top layer, the living cartilage, the subchondral bone is dead, and there's a crack between the subchondral bone and the rest. Histologic features for avascular necrosis are, on gross, a wedge-shaped area of subchondral sclerosis that often appears chalky. The articular cartilage is often detached but microscopically alive. The subchondral bone is dead, resulting in a crack between the articular cartilage and the subchondral bone. The interface naturally is alive with fibrosis, and histologic features for avascular necrosis are, on gross, a wedge-shaped area of subchondral.
So what happened with us, the reason we developed an interest in this to begin with was when I first got to Cleveland Clinic, I started noticing that I would get these occasional cases of AVN, but the clinical history on the rec said degenerative joint disease osteoarthritis. And at first I thought, that's probably just an error. Nurse may have written down something wrong, because oftentimes that the role of that is given to the support personnel in the OR. I don't know if the surgeon wrote that down. And John Wright started noticing the same thing, and we were talking about that. So I did a little bit of a deep dive. I took a few cases. I said, well, let me just see if that's what they saw. I went back and looked at the op note. I looked at the clinic notes. I looked at the preoperative radiology, and lo and behold, in almost all cases, we had a handful of cases that were misdiagnosed. And I didn't notice any particular trend with a surgeon or a radiologist. I just noticed happening. So that's kind of what led us to looking at consecutive arthroplasty specimens and seeing if this was a true problem or not. So then we looked at about 1,700 consecutive femoral heads. And what we found was, of the couple hundred AVN cases that were diagnosed, about a third of those were not recognized preoperatively. And it was an interesting mix. So about 3 to 4% in there of all the DJD cases that were thought clinically turned out to be AVN. And of the cases that were found to be AVN, we were around 16, 17%. And that actually turned out to be not AVN, but DJD, with no evidence of osteonecrosis. They weren't subchondral insufficiency fractures. They just thought this. So if you look at this in a practical standpoint, most of these patients are getting AP lateral plain films before. If there's no suspicion for that, they're not typically getting a frog view, which would be the better view on a plain film to see AVN, nor are they getting more sophisticated studies like MRI and CT scans. So they're basing what they do largely on the clinical, right? And if you think about the fact that AVN, most cases don't have any predisposing factors, it's easy to see that they could be easily missed. The radiographic features overlap considerably among DJD and AVN. And so we looked at this data, and it was interesting because when we compared it to the data at the Hospital for Special Surgery, it was virtually identical. So when I give you these ranges, 3 to 4% of cases of DJD turn out to be AVN, and about 16 to 18% of cases that we think are AVN turn out to be DJD. That's the ranges of the percentages that we and the Hospital of Special Surgery found.
Yeah, that sounds about right.
Patients.
That's my instinct for Mass General data as well.
And you kind of hope. So what would be the hope in this? Well, it also turns out that the patient population is, we had patients that were missed and patients that were found that had risk factors with them. So it wasn't solely that the patients that didn't have AVN were not chronic steroid users or had a history of alcohol. But what we did find was there was a greater percentage of older patients who lacked those risk factors, and that may have led to the fact that they weren't identified clinically, right? Because they weren't thought about. So it kind of made me wonder, there's always a bias clinically. We all carry one. So was some of this due to the fact they didn't think they had AVN because they didn't have some of the risk factors associated with it? Like I said, it wasn't restricted to that group, but there was definitely a trend, a trend of significance among that group. And I guess one of the hopes you have is if you identify a patient with AVN, of course, they have an increased risk of developing AVN on the opposite hip, and elsewhere, that risk is as high as 50%. And I guess the other point, which a lot of orthopedic surgeons are skeptical about, and I understand this, is if we identify AVN and there is a risk factor, is that risk factor modifiable? Can we go back to that patient and say, hey, maybe we can modify these behaviors? But if you don't know they have it and you don't know that they are at risk of developing it, you won't follow up in that manner. It's also interesting, I'll tell you one other thing is the rheumatologists tend to be much more supportive of us examining these, because I'll occasionally get a call on a patient, for example, rheumatoid arthritis. Rheumatoid arthritis patients can get routine osteoarthritis, not due to their rheumatoid arthritis. And they will often call up and ask me what the synovium looked like, because in their mind, if that synovium is inflamed and looks like rheumatoid, they're going to assume that the DJDOA was due to that and start some treatment relative to rheumatoid arthritis. But if it's not, they won't. So there's a lot of things that can happen as a result of pathologic review that's hard to quantify, right? But we know that, that it exists. The last point I'd make, and I know I'm going on and on, is, there's another point about this, and that is, if you look at a lot of the studies,
I was going to go.
One of the flaws in a lot of studies is that they use charges. I reviewed a paper not too long ago that was doing, it was like telling, something like $200 or $200 to $300 per, and I was thinking, wow, I would be very well off if I was getting that per femoral head, right? I mean, my life would have been very different. So anyway, but I thought that was kind of interesting, $200 to $300. In reality, I was looking up one of the things I wanted to do, and I was glad you gave me a heads up. I looked up our 2023 Medicare fee schedule for a non-fractured femoral head, just to remind myself. And my professional fee for that is $11.42. So now there's a technical charge of $30. I get that, so you're talking about $42. And if you add decals, about $21, and most of these patients we're talking about, right, are going to be in that category. Most of our arthroplasty patients would fall in the Medicare range. So, but as far as what I get for my interpretation, I think it's a great value, I mean, I just, and a lot of our, we've had mixed success. Cleveland Clinic tends not to force people to do things. So they don't do that with our surgeons either, but we do have a broad support, and if I see anything different, I'm usually once a week, I'm emailing one of the orthopedic surgeons, say, hey, I saw this in the, or I saw more inflammation in the synovium. Does this patient have some inflammatory arthritis of some sort? And it's interesting, the comments I get, I feel like they greatly appreciate it. Oftentimes they'll respond, yeah, by the way, they do. And this is what I'm thinking. And so
I should try that. I haven't actively emailed anyone about a DJ.
Yeah, no, we do this. So if I get an AVN or DJD, if there's a discrepancy, I always do that. And I had speaking of the very nice case of SIF, subchondral insufficiency fracture you showed, I had
that never gets, I've never seen that being reported, identified preoperatively.
No. Well, what we do, I don't know. It sounds like HSS will make that as a diagnosis. Both Dr. John Wright and I, if we see something that looks like that, I will look up the clinical history. Almost never do I have that classic clinical history where they say I was playing golf or I was doing this sudden pain, right? It's usually, so I'm always loath to actually line it. I'll say something like,
interesting,
degenerative joint CC comment. In the comment, I'll talk about this breach of the articular cartilage and this fracture that's developed callus, and that it raises the possibility of subchondral insufficiency fracture. I also, because I don't know for a fact, I don't want to implicate that the surgeon did anything incorrect. Some people would argue that they didn't need an arthroplasty. And since I'm basically alerting them to something that could be that, I don't feel the need to stick it in.
So you don't top line it. I think that's.
I don't, because like I said, if I was really being honest, you can get fractures in DJD, microfractures in the surface that look a lot like it. So, but I will send them an email. do send them an email, say, hey, by the way, I saw this in here, it raises the possibility. I'll usually get a thank you back, and that's as far as it goes. Most of these patients still have DJD, so I don't know.
Right.
I'm not sure that it would have changed what they happened to them, but you're exactly right. I almost never see it preoperatively diagnosed.
Yeah. So I wanted to take you to one of my two of the pet problems that some folks out in the community have. One is periprostatic infections, right? These are after arthroplasties. And so what is your approach to them? So we get these for frozen. The question always is, how many chucks do you put in?
Mm-hmm.
Where do you look? How many neutrophils? And I know you had this. So if anyone doesn't follow Scott on Twitter, you should, because he had this tutorial on infections in the periprostatic
PGI, periprostatic joint infection. Yeah, exactly right.
Yeah. So and tips and tricks about how do you rule in or rule out that infection, and what's our role? The other question I had for you is, when you pick up the phone and call the surgeon, what do you say? Do you say there's no evidence of infection?
Nope, I don't. And then it's a very good question. So first of all, I always tell people that your role as a pathologist is not to diagnose infection. If you think about how PGI, periprostatic joint infection, gets utilized, and I'm thinking more along the lines of the MSIS criteria, where we have major criteria like a sinus tract or 2 positive cultures of identical organisms where it's made, our role to identify the histology that suggests this infection is a minor criteria. A minor criteria along with elevated CRP and ESR. We are minor criteria. We don't establish infection. We provide a piece of the puzzle. So it's really, I think even some surgeons are confused with that, but we promote the MSIS criteria as being, and I believe we have in the article that we wrote for journal,
I'll put it out there.
And so I tell people, think about your role is that you're not establishing infection, and basically by following those guidelines, I think the most accepted is the greater than 5 neutrophils and 5 distinct different high power fields.
Is it consecutive or just random?
No, it can be random. I don't think consecutive. And in many cases when it's very obviously infected, you'll hit 30 or 40 in one field, right? So you kind of, I count it all the time? No, but if I'm counting, we had the same discussion about mitotic activity separating D-diff liposarc from, well-differentiated liposarcoma at the last USCAP. If you get down to counting, you're probably negative, but we do that because we still need some standard criteria. Right. So if it meets the criteria at frozen, I call the OR and say it is positive for significant acute inflammation, right? And if it's negative, I say negative for significant acute inflammation. Now you should know that when I first got to the clinic, there were some surgeons were actually saying, well, what is the count? People would have to count, 10, greater than 10, greater than 20,
Yeah.
So I had an opportunity, and in fact, Dr. Wright joined me this endeavor. We went and talked to the chair, we talked to the orthopedic surgeon, and we basically got everybody on the table, which was still amazing to me that we got a lot of surgeons to agree. But basically we said, look, this is what we're going to do. We're not going to give you a count, but what we are going to do, and we're going to follow the MSIS criteria, which they like. If we use the word significant, that tells you it's greater than 5, per 5 high power fields. If we say negative, it's less than that. And that way we don't get into focal acute inflammation. So I would, at the Cleveland Clinic, we also, all of us, even though we're so specialized, we also do general frozen section coverage. Okay. So, but you have backup. You always have a backup. So someone could call me or John Wright or Karen Fritchie, to come take a look at a case that they're worried is borderline or not sure if it actually meets the criteria. So it was in our best interest to try to get everybody educated and comfortable with the terminology. And so on my YouTube channel, I created a video, and it's funny, I've referenced that video on Twitter before, but that video was primarily made for our pathologists doing frozen sections. So they would understand why because it was also an attempt to understand, well, why do I need to interpret this at frozen? What is an antibiotic spacer? Why are we doing, what is 2-stage surgery versus 1-stage surgery? Why is this significant? So it was an attempt to educate them about that. But yeah, to answer your question, positive for significant acute inflammation and negative for frozen. And when I sign them out, I will say, significant acute inflammation suggestive of periprosthetic joint infection, or negative for significant, and that's all I say. One or the other. Sometimes I might add in, mostly fibrin or,
Yeah.
but that my line diagnosis, because I know how far the surgeons are reading, they're not getting past that one. So I want them to say it's positive versus negative, So,
Yeah.
but yeah, that's exactly how we handle it at the clinic.
And how many chucks would you put through at frozen?
Yeah, and that's a good question too. I don't know that there's a great answer. We typically, do one section, at frozen. We don't put the whole specimen in. We typically don't. We accept, now, if you do that, you have to accept the fact that somewhere around 3 to 5% of all your cases you will have a positive result due to sampling that may have been missed at frozen. Now, whether it would have been picked up or not, I don't know, because we still see that occasionally, even if there's no other tissue to submit it. In other words, all the tissue was submitted at frozen. But our typical practice is one piece per section that comes in. So if it's, for example, synovium number 1, synovium number 2, synovium 3, they all get one section at frozen. And we don't usually submit all the remainder of it for permanence either. Typically one more additional section if there's tissue remaining. So we don't typically submit all of it, in that manner, unless there's something like, let's say it came in with a suspicion for alval or something like that, we might pursue that more. Although I've even started pursuing that diagnosis even less now too. So,
what happens if you do end up with neutrophils on the permanent that you didn't see on the frozen? Have you gotten a lot of pushback from the orthopedic side?
Not really. No, I'll say email them on every case like that. I let them know that, because one of the first questions is oftentimes, did someone miss something at frozen?
Right,
And
of course.
I'll be quick to point out, no, this additional material that was not evaluated at frozen revealed significant acute inflammation. Most of the time, again, if the surgeons are using the criteria correctly, most of the time, if they really strongly suspect infection, they will handle it like an infection, and that is they have other parameters that are going on.
Right.
So the most common response I get is, yeah, no problem, I handle it like an infection anyway. Every once in a while they didn't. Now it's interesting because I've kind of wondered what happens to those patients, because those aren't patients that are typically, we're not talking about purulence here. We're talking about just some foci that meet the criteria. And we know that, when we set criteria like this, it's somewhat arbitrary. We're trying to establish a test with X sensitivity, X specificity, but it's not perfect. So there's going to be some cases we think are infected that probably aren't, and some cases that aren't infected that probably are. So you're going to have that kind of discrepancy, but they do accept the fact that we've got. I want to say last time I checked, we're looking at about 3%. At the high end, 5% of cases may have sampling error associated with it.
Okay. Yeah.
And sometimes I will say, when I say that, I'm also including cases in which we had multiple specimens and there was clear cut significant acute inflammation, and they may have had another specimen that wasn't, but in permanence it was. That would not have changed surgery anyway. So I'm including those kind of cases in there as well.
Right. I wanted to shift gears and talk a little bit about osteomyelitis, right? So this is one of the most common specimens we see, Absolutely. And I know you cover it in the review paper. So it sort of got me thinking about what the minimal criteria are for acute osteomyelitis. Yeah, so that's sort of the heart of the.
It's a good question.
So we all would agree that if there's a sea of neutrophils, there's dead bone, there's this ratty-looking dead bone, there's a little bit of new bone, and the bone is reacting to whatever's going on. That's osteomyelitis. What do you do when you see what do you do when you just see a few neutrophils here and there? What are your minimal criteria for something osteomyelitis?
So it's interesting. I have 3 things that I have to have. They of variable degrees, right? I need inflammation. I need evidence of bone destruction. When I say bone destruction, that could be remodeling or something. It doesn't necessarily have to be necrotic bone, but I need evidence that there has been some damage or reaction to the bone. And I need context. And I think this gets to your point too. I see this more commonly with chronic inflammation, where you'll get a bone that's not, there's no indication it's infected. It's got some patchy lymphocytes and plasma cells. I will typically ignore that if it's in a setting that doesn't make any sense for it being infected, right? My threshold is lower if this is a case a podiatrist is doing and a patient with a long-standing ulcer, for example, on a toe that sort of has a known history, has been treated for osteomyelitis. So there's a little bit of a judgment call here. But I have to have all three of those things to actually make the call. Not necessarily a necrotic bone, but I need to see some evidence of bone remodeling. Certainly in cases where I'm looking at a margin, and I should preface this by saying, you know, we at Cleveland Clinic, we don't get asked to look at margins. Every once in a while, someone will ask me about that. A lot of ours are disarticulations, so we don't have a margin per se. And I've tried to move people away from that logic, you know, based on what, you know, podiatrists tend to be more concerned with that than surgeon. And I think it's because a lot of surgeon mentality is that I'll wait and see if it actually heals. Right, which is, you know, no matter what you say or I say on it, if that ulcer doesn't heal or that flap that they put doesn't heal, they may end up with an amputation above that site as well, and that's going to be a better indicator if there's actually infection remaining at that particular site. So we don't get asked about margins very often.
We get asked about margins all the time here at the BI, and I remember at the Mass General too. So we take this en face section of the margin. And those can be very challenging to interpret.
Yes, absolutely.
Fortunately, a lot of the time, the margin is the articular face, which is easy. But exactly. At times it's the bone, and then you see a little bit of hemorrhage and a few neutrophils. But I love your criteria, right? Context, response from bone, and inflammation. And if you don't have most or all of those features, I think you really should reconsider the diagnosis, because you can see neutrophils in osteoarthritis.
Absolutely.
Related to crystal disease.
You can. And like you said, in osteoarthritis, those pseudo abscesses, they can be associated with some bone destruction and bone remodeling. But the context is not right. When you look into it, there's no evidence of sepsis. There's no, so that's why. I used to just say inflammation and destruction, and then a few years ago I added context to it because I thought, that's, you know, and that's what made me think about that, was I thought, well, there actually, someone could argue in this case of routine DJD that there's some bone destruction here. So I thought, well, let's put the context in there. And so it's one of those things that requires pathologists to do a little more than just interpret, you know, the pathology. We have to be more involved. And I think when we're more involved in pathology and pathology cases, it also makes a greater argument for our value, you know, which is, I think that's been one of the problems that we've had in the orthopedic arena, is people begin to look at a lot of our orthopedic as just so routine that they didn't need our involvement, you know, and the surgeons sort of caught wind of that. They didn't, you know, they said, why am I even sending this to pathology? You know, so I think the surgeons that we interact with, we want to provide value, want to provide best patient care. And I think that our role in that is important. You know, so it's gotten me to the point that if I had a relative that was undergoing arthroplasty, I would insist that they have their pathology sent to say, look, we're going to confirm it. We're going to confirm that you're okay, or, you know, there's no evidence of a pre-existing neoplasm or sepsis or AVN or something that we didn't pick up preoperatively.
Yeah, Scott, I think that's a good note to stop on. Thanks for doing this. This was awesome.
Yeah, thank you for inviting me. And like I said, I was thrilled I thought the article came out really well.
It did.
And Nushin's, it's interesting because she's not a fellow with us. She's at Dartmouth now, but a junior faculty member that I think Goldblum was her mentor through USCAP. But at any rate, so that's how, and she's been a fantastic uprising junior faculty member who's worked with John Reith and I on.
Oh, I didn't realize that.
Right. So
awesome.